Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble.
On today's episode of 1PM, our resident respiratory scientist, Jason, will be talking to us about the management of asthma. Take it away, Jason.
Hi, my name is Jason. Welcome to the First Principles of Medicine podcast. I'm joined by Dan, Adian, and JT. So today we're discussing the long-term management of asthma. And to really understand it, you got to understand what makes up the airway. Okay? So I want everyone to think of the airway as a tube which is made out of 3 layers. So can anyone tell me what those 3 layers would be?
The outer, middle, and inner layers?
Yeah. So let's start from the outermost. Does anyone know?
The smooth muscle?
Yeah.
Perhaps?
So the airway smooth
Yeah.
muscle, okay?
Yeah.
So that's one layer, which is important to understand. So what would be the middle layer?
Would it be the cartilage?
Yeah, so cartilage is part of it, but the cartilage as a whole makes up the airway wall. So other things which are in the airway wall are things like, does anyone know?
Connective tissue, goblet cells,
Yeah.
epithelium.
Yeah, so you got blood vessels, well, what Dan said, yeah, epithelium. And it's important to know that you've got the goblet cells and submucosal glands. And do you know what those functions are?
They have secretory functions.
Yeah,
perhaps.
and what do they secrete?
Go for it, Dan.
Mucus.
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 Yeah. Mucus.
Okay. Now, what is our most innermost layer? So the third layer.
The endothelium? Epithelium?
No, I'm thinking like more functional
Ah.
layers, like
The mucus.
The mucus.
yeah. So the mucus layer. So
Oh.
Oh, yeah.
That's what it is. Yeah.
okay. So if you understand these
I've gone
3
too fast.
layers,
Is it actually 3 layers then? So it's 2 layers plus the mucus, is it?
So you're treating the mucus as a layer of the...
Yes.
It's going to be a big discussion if we
Yeah.
get into
just
Okay.
layers.
all I want you to realize that there are 3 main layers. You've got the airway smooth muscle, which is the outermost.
Yeah.
You've got the airway wall, and you've got the mucus layer, which is
Sure.
the innermost.
Okay.
And the lumen is.
So these are not anatomical layers.
They're kind of anatomical layers. I'm just trying to help simplify things,
Okay,
JT.
alright. No,
okay?
I'm just
Yeah,
confused.
yeah.
Okay.
Yeah.
I guess because that middle layer, you could like subdivide it more, right, into different layers. But
Okay.
in terms of the function of the airways,
Yeah.
the middle layer, like they do the same thing. They all part of the same function.
Okay.
And then the mucus is a separate function.
Yeah. So mucus
Okay,
layer is the
I see.
innermost. You got the airway wall, which is like gives the structure because it has the
Okay.
cartilage,
Yeah,
has
yeah.
the goblet cells, blood vessels, and then you got the
Okay.
outermost layer. Okay. So now that we understand those 3 things, can we think about what effect asthma has on each of those layers? So starting on the airway smooth muscle.
Does it cause the constriction of these smooth muscles to spasm?
Yeah.
And
so
then
you're on
cause
the
the
right
airway
point.
to narrow, the lumen to narrow, consequently?
One of the key features of asthma is that the airway smooth muscle is hyper-responsive. And what is it hyper-responsive to?
I think, no, so all the allergens that
Yeah.
people could be allergic to.
To triggers. And by what I mean by hyper-responsive is that, for example, when an asthmatic has an upper respiratory tract infection or exposed to triggers like cold air or their pet,
Pollution.
pollution, things like
Smoking.
that, the airway smooth muscle contracts, and when it contracts, it narrows the lumen of the airway, okay? And if you've got a narrow lumen, that makes it harder for air to pass through.
Okay.
Now, moving on to the next feature, the airway wall. What happens to the airway wall in asthmatics?
With chronic insults, don't you get remodeling? So
Yeah.
it gets thicker, you get
And what
hypertrophy of
causes
the
the
mucus.
remodeling?
What causes
Yeah.
chronic inflammation?
So what Dan said, chronic inflammation causes airway remodeling, okay? And what do you mean by airway remodeling?
As in, basically, it just gets thicker, you get more, it's called
Fibrosis?
mucus.
Scarring? Could you?
Goblet cells, you probably get some scarring. I mean, chronic
Yeah.
inflammation would cause that,
So,
yeah.
so
If you get more goblet cells, does that mean you get more mucus production?
hey, that
Okay.
no spoilers, JT.
No,
no
okay.
spoilers,
Go-
but
going too far.
no, you're on the
Okay.
right point.
Are you
So
going for hypertrophy and hyperplasia?
yeah, so basically, when you've got inflammation, the airway wall thickens. Okay, there are more blood vessels because inflammation causes like angiogenesis. You get larger submucosal glands, larger goblet cells, and that leads me on to the third point, right? The mucus layer. What happens to the mucus layer in asthmatics?
Thicker.
Yeah.
Thicker.
Yeah, and becomes thicker. It becomes thicker because of
Add some
those,
C's.
because of that inflamed airway wall. Okay.
Does the mucus layer get thicker because the airway wall is getting thicker, or does the mucus layer get thicker because there's more goblet cells producing more mucus?
Yes, the second thing you
Cure
said.
the
Yeah,
mucus
sorry.
layer.
When the airway wall is inflamed,
Gotcha.
that leads to
Yeah.
goblet cells
Yep.
and submucosal glands becoming bigger
Yep.
and more of them, which leads to increased mucus secretion.
Yep.
And
Okay.
then the airway is even more narrowed?
Yeah.
Okay.
So all those three things work in conjunction to narrow the airway.
Yep.
Okay, so as you can imagine, each of those layers can pretty much be targeted with asthma medications.
Sure.
Okay.
Yeah.
So what would be a drug class which would affect the airway smooth muscle to help prevent the hyperresponsiveness?
Anti-hyperresponsiveness medication? I don't know.
Go straight for the jugular, JT.
Well, I actually
Okay.
don't know.
Beta-2
I don't know the
agonist.
class. Okay,
Yeah.
sure.
So Dan said
Oh,
beta-2
right, okay,
agonists,
yeah.
okay?
Yeah.
So the way beta-2 agonists work is that they help to relax the airway smooth muscle,
Yeah.
which helps to open up the lumen,
Yep.
okay?
So bronchodilation.
Okay? And basically beta-2 agonists, they're known as relievers because they provide immediate relief
Yeah.
and relax that airway smooth muscle.
Yeah.
Okay? And beta-2 agonists can be broken down into short-acting beta-2 agonists and long-acting beta-2 agonists, okay?
Mm-hmm.
And basically the only difference between those two is their duration of action. And the classic example of a short-acting one is salbutamol or Ventolin. It's a classic blue puffer you've probably seen many times
I have it in
before.
my bag, in fact, in case you
Yeah.
guys want to have it now. So.
Is there a common suffix for a short-acting beta agonist?
Not really. Just salbutamol is the
I know
common one.
alls.
Alls is beta blockers, right?
Olo is
All
beta
all
blocker.
Yeah, all.
I think Terol maybe for long acting.
Just remember salbutamol. Just remember salbutamol.
Mm.
Okay. for
Sorry,
short-acting.
what's the brand generic name
Ventolin.
for? What's the generic name for Ventolin?
Salbutamol.
Oh, okay.
Yeah.
So possibly could be
So
Alol.
just the all. Oh, I don't know because there's
I don't
some-
know.
that-
Dude, there's
yeah.
no
Okay.
just.
But the
I
gen-
don't think
the-
there's a
yeah.
pattern.
The
Just-
generic is salbutamol.
Okay.
Yeah.
Okay.
The brand names are like Ventolin, Asmol, stuff like
I think there could be a suffix, but all right.
I think you could be wrong.
I don't.
Okay, so that helps manage the airway smooth muscle
Yeah.
problem. Okay, now what about the airway wall inflammation problem? What drug class could we give?
I think we're gonna have to go for the steroids.
Yeah, so inhaled corticosteroids or steroids, and they are
Oh,
known
'cause
as
it's anti-inflammation.
Yeah.
Inflammation. Yeah.
Yeah.
Okay.
yeah, so they're known
Cool.
as the preventers because they don't provide immediate relief. They're more for continuous prophylactic use.
Sure.
Okay, because over time, the inhaled corticosteroids help to reduce the inflammation of the airway wall, and they'll probably help with the mucus secretion as well.
Can they
So-
reduce the thickness as well?
Well, but you're just reducing the inflammatory state, right?
Oh, okay.
Yeah,
That would end up reducing the thickness of the airway.
Oh, to back it
Wall.
to its initial state
Yeah.
before the inflammation.
I just think I try and think of it as the inflammation as a stimulus for the chronic, like increasing of the thickness, airway remodeling.
Yeah.
So if you've got that chronic inflammation, that chronically stimulates the airway to get thicker.
You're
Okay.
overthinking this. Airway inflammation leads to remodeling, and it contributes to the obstruction of the airways. Okay, so by
Yeah.
giving an anti-inflammatory, that helps reduce the inflammation.
I think though you're actually right, JT. So you can get long-term airway remodeling that if it's bad enough, you don't reverse back to what it was pre-remodeling. So- I know, like for example, people who have asthma, who've had asthma a long time that hasn't been controlled, that the airways are much thicker than controls, right? So non-asthmatics.
So their baseline is
So the baseline
higher
will be
now,
higher.
right? Yeah.
So the like what Jason was saying though, like the
Yeah.
preventers will prevent it from getting worse, but it can't necessarily undo all the damage if you have enough damage.
Yeah, okay, that's
But
what I was
yeah.
shocked about. Like,
Yeah.
I didn't know you could.
Yeah.
Yeah.
Okay. And then you've got the mucus layer, but in reality, there aren't that many drugs which are used to directly target the mucus layer. So to summarize, the mainstay of treatment of asthma, or long-term asthma management, is the use of beta-2 agonists and inhaled corticosteroids.
Mm.
However, there are also other drugs which they use, okay? You've also got things called like muscarinic antagonists, leukotriene receptor agonists, and things like those, okay? But it's not important to know. What you need to know for asthma management inhaled corticosteroids and beta-2 agonists are your mainstay for treatment. Okay, and because they're the mainstay for treatment, you can usually get puffers which contain both of them in the same puffer, and these are known as combination inhalers. An example of that is like Seretide or Briolipta, but there are like 5 or 6 different puffers. Okay, but they're just different
What's
brands.
the most common one?
Seretide, I think.
I think Seretide's
And that's a SABA or LABA plus an ICS?
I think it's
LABA.
LABA
It's a
plus
LABA.
ICS.
Yeah,
Okay,
usually the
okay.
combination inhalers include a long-acting beta agonist and an inhaled corticosteroid.
Oh, and the SABA is usually for acute management.
Yeah.
Yeah. So now that we understand the drug classes, now I want you guys to think about the principles of long-term management. And basically the principle to go by is that long-term asthma management is a stepwise approach. Okay? So what I mean by a stepwise approach is that as your first step of management, you start off with a low-dose inhaled corticosteroid, and you also give them a short-acting beta agonist just for PRN use during like an acute asthma attack. Okay? So the next step in escalating their treatment, if there are symptoms still present. So what are the symptoms you're looking for to really tell you as a practitioner that their asthma is still not well controlled? What are the sort of questions you're going to ask them to gauge how well their control is?
Well, I imagine because asthma, obviously the symptoms of asthma is difficulty breathing. And if the SABA that you give them is to relieve their difficulty breathing, you might ask them how often they're using their SABAs, how often they're feeling like that.
Yeah, so you get concerned if they have to use it like multiple times a day, and if they just feel they're not getting any relief from using it, like the use of the short-acting beta agonist on repeat, that's probably a bad sign, meaning that your asthma management is not up to par. Okay? So that was your first step. If you notice that the low-dose inhaled corticosteroid is still not working that well, you probably want to add on a combination inhaler where it contains a low-dose corticosteroid and a long-acting beta agonist, and then you wait and see how well they react to that. Okay? So that's the second step of escalation. And then once again, you then see, are they managing well at home? Are their symptoms still persistent? Do they still have to use a short-acting beta agonist? Okay? And that's when you get to the more complicated management steps and possibly referral to a specialist. So the add-on therapy, if like a combination inhaler is still not providing enough relief, are things like increasing the inhaled corticosteroid dose. Okay, you can also do things like consider the use of a leukotriene receptor agonist. I didn't really mention that before because it's usually used sparingly if the asthma is not well controlled. There are also things like muscarinic receptor antagonists, which can be used in conjunction. And you could also consider the use of a low-dose oral steroid. Okay? So now that you guys understand that, can we think of some of the management issues you'd come across in a patient with asthma?
Compliance
Yeah.
with medications.
So what do you mean by compliance?
Maybe they don't want to take it. Maybe they just don't know how to take it properly. Maybe they're not using the inhaler correctly.
Okay.
So I remember, speaking as someone who has asthma, the correct way, if I remember, Jason, is when you take your inhalers, you need a spacer, because I think all the science shows that using a spacer allows you to actually get the inhaled powder to the lungs where they need to be. But I don't know if you guys have used it before. It's very annoying to, 2 times a day have to go and get this bulky thing, chuck your inhaler on it, stand there like an idiot and breathe into a tube for like 30 seconds. It's not like a big deal, but that is a thing that can affect someone's compliance.
Yeah. And the other important reason for using a spacer, other than like what Aideen mentioned, that more of the drug goes into your lungs, is that by using just the puffer itself, a lot of the drug can go into the back of the mouth. And one of the issues is that when you use a steroid, if the steroid's going to the back of the mouth, that can increase the risk of getting things like thrush, because steroids can inhibit the
immunosuppression.
Yeah.
And then candida or whatever.
Yeah. So you can maybe scare a patient by saying you could get thrush if you don't use your spacer properly. So Aideen just mentioned poor inhaler technique, and Dan mentioned another issue with poor compliance. And one of the main reasons patients have poor compliance is that they don't really understand the difference between the preventer and a reliever.
Mm.
Okay? So think of this, okay? You're taking this preventer every day, which is the inhaled corticosteroid, and you're not really feeling much an effect. So why would you continue taking it? Whereas when you take your short-acting beta agonist, it provides immediate relief and you feel so much better. Okay?
Mm-hmm.
So it's pretty rational for a regular person off the street to be like, you know what, this preventer is a waste of time. It's probably causing me side effects. Why should I continue using that where the only thing giving me relief is the beta-2 agonist? Okay? But what the patient can sometimes not understand is that by using the preventer, you're actually preventing long-term airway remodeling because the corticosteroids help to keep the asthma at bay because they help to reduce that inflammation.
So, Jason, would you say this is up to patient education?
Yes. So patient education is extremely important.
Yeah.
And it can actually be life-saving in this case because sometimes a patient can have such a severe asthma attack that a reliever won't be able to open the airway enough because the airway wall was so inflamed and there's so much mucus that even relaxation with the airway smooth muscle with the Ventolin may not open the airway enough.
Too thick.
Okay? And can anyone think of the last important management issue?
What's this related to?
To lifestyle. So
Just be aware of your surroundings, your allergies, your triggers.
But the issue is sometimes the triggers, you can't get rid of them, right? You can't get rid of cold air. Sometimes if your triggers are present at work, are you just going to euthanize your dog if if it's a trigger for you?
Well, that depends on your values, right? Whether or not you want to be triggered every day or do you want your dog to bring happiness? I don't know.
Yeah.
Surely you're going to balance that by yourself.
Yeah, so that's one of the main issues with asthma management is that sometimes people are just continually exposed to their triggers and there's nothing you can do about it as a practitioner except euthanize their dog. No.
Well, is there really nothing you can do for the mucus lining? Is there any anti-mucus things?
I'm glad you asked,
or any
JT.
suction of mucus?
This is
Can you
my
do that?
honours year, my 6 months of honours.
Let's go, baby.
So
Let's
my
go.
boy Peter Henry, okay, he was investigating the effect of azithromycin on mucus secretion.
That's
okay?
an antibiotic. Right?
Antibiotic. So
Yeah, okay.
the issue is we think as antibiotic, that's the only thing it affects is the bacteria,
Yeah,
right?
Yeah.
But some of the studies he was doing in mouse models was actually showing that azithromycin has a direct effect on the goblet cell and submucosal glands, which is independent of its bacterial effect.
So it's like a side effect.
Just
Not
like
a side effect, it's more like we just don't know what the hell is going on. We
Happy
just,
side effect.
Yeah, no.
Yeah.
What's side effects?
just like
aren't
that,
necessarily
just like that
bad.
heart attack drug, that
Aspirin.
blood pressure drug.
Oh, the
that
sildenafil.
helped with your
Viagra.
and fun fact,
Never
but
mind.
mucus secretion is, I would say mucus secretion is probably the least important factor in asthma, but it's an extremely important factor in conditions like, can anyone guess?
Cystic fibrosis.
No, cystic fibrosis is the main one because they produce a crap ton of mucus, right? There are a few agents, but if you had to compare like the amount of drugs available, which are steroids and airway smooth muscle relaxers compared with mucus drugs or whatever, they're considerably less.
Do asthma patients also get a lot of sputum?
Yeah.
When they're, I assume not when they're not well controlled. So they have.
Yeah, they
okay.
they do
Cool.
tend to get sputum, but I wouldn't say it's the most important feature. It's more the
Right. Okay.
the hyper responsiveness of the airway smooth muscle. And another important thing to know, I should have mentioned earlier, is that with COPD has a very similar combination inhaler which is used, but this combination inhaler is slightly different. It contains a long-acting beta agonist and a long-acting muscarinic antagonist, okay? So inhaled corticosteroids are not used regularly for COPD patients because it increases the risk of a pneumonia. Basically, inhaled corticosteroids are only used when they have an acute exacerbation of COPD.
Right, okay.
So that's an easy thing to get mixed up.
Cool.
Okay?
Wait, you were just mentioning anti-muscarinic, right?
Yeah.
Muscarinic.
Muscarinic.
Muscarinic. And is that used in asthma patients?
That is used in asthma patients,
Okay.
but it's one of those add-on therapies.
Okay, not the key
including
ones.
That's like
Okay.
third line.
including
fourth
like
line stuff.
leukotriene receptor
Yeah.
antagonists,
Okay.
but those are more like specialist drugs.
Okay.
My understanding, muscarinic receptor, when it's activated,
Yeah.
helps, like, doesn't it cause constriction of the airway smooth muscle or something? I've totally forgotten now.
Is it related to cholinergic?
Yes. It is.
But I don't know
Yeah.
what happens afterwards downstream.
Yeah.
Yeah.
Do you know, Aideen, or?
No, I think Jason's right. Muscarinic in the airways, muscarinic receptor agonists cause bronchoconstriction, and then bronchoconstriction.
Oh, so anti-muscarinic.
So anti-muscarinics antagonize that.
Bronchodilation.
But also muscarinics have a secretory effect.
Yeah.
So if you antagonize muscarinic receptors, you might reduce mucus secretion, potentially.
Yeah.
So
But I do know in COPD, you do use anti-muscarinic, right?
Yeah.
Okay.
That's my point. So it's just easy to get mixed up. But
Okay.
what I wanted you to remember was that for asthma, you use long-acting beta agonists and inhaled corticosteroids.
Okay, good.
Whereas in COPD, you use long-acting beta agonists and long-acting muscarinic antagonists.
So LAMAs and LABAs.
Yes.
Yeah,
But
okay,
it's very
I see.
easy to get mixed up. So
I
you
see,
may
I
not.
see.
Yeah.
I didn't even know that, so I wasn't going to get that mixed up.
Yeah. Another thing to note
Oh.
too. Okay. Does asthma mainly affect expiration or inspiration?
Which one is
Inspiration.
No. 50%. I didn't want to mention this before, but yeah. So
Expiration.
asthma affects expiration.
it? Before you go into that, why don't you ask JT if you can try and explain why it's expiration that it affects?
Well, I was trying to explain it was inspiration.
Okay, but like now that you know it's expiration, can you think of why it might be expiration?
No.
Okay, no, Jason, go.
Wouldn't it be both?
You know what? I don't actually understand why it affects expiration, mate. Because you think that narrowing of the airway would affect both inspiration and expiration, but for some reason,
So does anyone know?
obstructive diseases like COPD and asthma mainly affect expiration.
I think it's because if you think what your lungs are doing during expiration versus inspiration. So versus inspiration, you are pulling the diaphragm down. So you are increasing the intrathoracic volume. So you're literally pulling the lungs apart. So you're pulling the airways apart, right? So even if you have a narrowed airway, it's helped on inspiration because those narrow airways are now being pulled open. But then on expiration, you're getting a reduction in intrathoracic volume. So your already narrowed airways are now narrowing more. So the lungs are getting smaller, right? The volume is getting smaller. So then it exacerbates the problem of having narrow airways.
But you have smaller volume. Don't you have higher pressure, and then higher pressure will help it like spew out?
No, because the pressure that's spewing is not pushing open the airways again.
It couldn't?
No, because you are reducing the volume by breathing out.
You're reducing the diameter, you
The
mean?
diameters, yeah. So that's the volume of air that goes through.
Oh.
Because a
Right.
reduced diameter is equivalent to a reduced volume, pretty much.
Yeah, yeah.
Okay.
Yeah.
Of the
Okay,
bronchi,
okay, yeah.
Bronchioles, bronchi.
And just to recap, basically.
Do you want to get one of us to recap it?
Yeah. Who do you?
Jones in for a recap over there.
Okay, so the first principles of asthma, you have to consider the airway in three main layers. You've got the outermost smooth muscle, you've got the middle epithelial connective tissue layer, which has goblet cells and mucus glands, and you've got the inner mucus layer. This is important because when you're trying to treat asthma, you target these layers. The middle goblet cell /
Airway
wall layer, you try and prevent airway remodeling and thickness of the airway wall. You try to reduce the airway constriction or bronchoconstriction by using either a short or a long-acting beta-2 agonist. The stepwise management of asthma, to my understanding, you start with a low-dose inhaled corticosteroid, ensuring that the patient is well educated on how to use an inhaler and the importance of avoiding triggers in their surrounding environment. If it's not working, and you can tell this if they are still having to use their inhaler multiple times a day, despite being on an inhaled corticosteroid, you then might consider a combined inhaler, which will involve, again, a low-dose corticosteroid inhaled and a long-acting beta agonist. Again, if this isn't working, then you can consider upping the inhaled corticosteroid dose or consider referrals to specialists for some of those more fancy drugs, such as leukotyne receptor antagonist or something.
The big boys.
Yeah. So that's pretty much the long-term management of asthma. Thank you for listening to today's episode. Feel free to check out the Notion page as well as leaving a review on Spotify. Cheers.
Thank you.
Good reviews only.
We also have antidotes.
That depends on your values, right? Whether or not you want to be triggered every day, or do you want your dog to bring happiness?
Thanks for listening, guys. If you liked this episode, feel free to check out the rest of our episodes available on Spotify. Leave us a review and a like. And don't forget to check out all the other resources, including Anki decks of each of the conditions we talk about on the podcast, available on the 1PM Notion website. Thank you.